have Amanda Brummel with us. I'm going to introduce her in a second, but I did just want to make you aware of some upcoming events through the PCPCC. We have the Fall Summit coming up in October 25th. Now what's different about that is it's actually being held in Chicago this year, not Washington, D.C., so make sure you put that on your calendar. And I am just so thrilled to actually introduce Amanda Brummel and also kick off what has been quite a journey on this second edition of our resource guide around integrating comprehensive medication management into the PCMH. And just to let you know about, for those of you that might not be as familiar with our first guide, it's been one of the most downloaded and requested resource documents that the PCPCC has been produced. And actually AHRQ, the Agency for Healthcare Research and Quality, has included it in their Innovation Exchange Quality Toolkit. So just my colleagues on the Medication Management Task Force and everybody who's been involved with that effort, it definitely has been a broad stakeholder effort to make that such a successful guide and really highlighting the importance of getting the medications right in patients. That again, I just want to thank everybody for being on this webinar. The other individual, the other co-lead, I co-lead the Medication Management Task Force along with Ed Webb. You'll be hearing from Ed a little bit later as he sort of wraps up and goes over what the new guide entails at the end of Amanda's talk. This is being recorded and the slides will be available and the recording by tomorrow, so if you have some of your colleagues that weren't able to make it, please just let them know that this is going to be recorded, or if you know of others that you might like to share this with later, it will be on the pcpcc.net website by tomorrow. So with that, let me introduce our speaker. Amanda has years of experience. She is a PharmD. She's been working in medication therapy management for the past 12 years. She's employed by the Fairviews Health Systems, which is a not-for-profit integrated healthcare network. And just as she will mention, Fairviews System is a pioneer ACO. They're one of the top 10 recognized and quality healthcare systems in the United States, and they have been very active really throughout their Fairview history in the last 15+ years, really incorporating clinical pharmacists as collaborators, as providers of care in collaboration with the physicians, the nurses, and the patients there. She's been the clinical supervisor for the MTM department, the MTM operations and program manager, and in 2010 became the director of clinical ambulatory pharmacy services. In this position, Amanda works closely, again, with a medical group to ensure that pharmacy integration and is responsible for the development and oversight of the MTM program, as well as retail clinical services development. The MTM department there actually includes 24 MTM practitioners in 27 different locations. Amanda has helped to develop and implement multiple MTM employer programs and has worked with multiple payer groups to receive payment for MTM services. And I know a lot of us are asking questions about how we can get these services paid for, and I think Amanda has a lot of insights there. She's also an adjunct faculty member of the University of Minnesota, and she teaches the elective course, How to Build an MTM Practice. She also co-developed an online CE course on building an MTM practice. Just also of note, she's one of the co-authors on the article, Medication Therapy Management, 10 Years of Experience in a Large Integrated Healthcare Systems. I think that came out in 2010. And so with that, it is my pleasure to have Amanda speak today and really share with us how this vision of integrating comprehensive medication management into the medical home, into accountable care organizations, can be and is successful. So with that, Amanda, please take over.
Thank you so much, Terry, and thank you all for joining us today. It's my pleasure to be here joining you. So today, I'm really just going to give an overview of our MTM program at Fairview, just so we kind of have a common understanding of where we're starting from. I want to also discuss the role of pharmacy in the medical home and accountable care organizations, and then give and share our experience with Fairview Pharmacy Services and our MTM program within the care of our medical home and ACO. So our path here at Fairview, as Terry discussed, we are a non-for-profit organization. We were actually founded in 1906. Want to kind of give the map of Minnesota there. The stars are where our hospitals are within that map. We partner with the University of Minnesota, and that partnership started in 1997 as we joined with the Academic Health Center there. We were a top 10 U.S. health system. In 2009, we have about 22,000 employees, so a pretty big integrated health system. We got 2,500 physicians, 7 hospitals, 55 specialty clinics, primary care, 30 retail pharmacies. So as you can see, we kind of span a great area in kind of all areas within the health system, which really has helped us with our journey in accountable care. Our MTM program started in 1997, and that really became a program when the University of Minnesota and Fairview joined together. And basically this new philosophy of practice, pharmaceutical care, was being taught at the university, and they needed a place for students to learn. And so Fairview said, we'll develop the practice, and that's really where our partnership started with the university with the MTM program, and really follows the comprehensive medication management model, also known in our world as pharmaceutical care. We've cared for over 15,000 patients during this journey, and we've resolved over 78,000 drug therapy problems. As Terry mentioned, we do have 24 MTM pharmacists now at our site at 27 Twin Cities locations. We also have a network of pharmacists in Duluth. And just to kind of put it in perspective, our pharmacists practice within our primary care or specialty clinics, and so they're embedded right inside the clinic. We take appointments just like a physician may take an appointment. We have our own schedule and see patients right in that clinic setting. This is important for me. I think it's important for all of us, but it's important for me each time I talk to make sure that we're all grounded in the same background of what medication therapy management means to me and what I mean when I say that. So it really follows the line of the PCPCC's comprehensive medication management model. It's built upon the philosophy and process of pharmaceutical care practice, and it's really that holistic approach to a patient's healthcare needs. So when we're working with a patient, we do an assessment with them. We want to make sure that all of their drug therapy is indicated, effective, safe, and convenient. That's really the pathway that we take when we're doing a medication review. We have to look at all of those components. In doing that, we identify drug therapy problems, and we categorize those drug therapy problems based on the indicated effectiveness, safety, and convenience. We then create a care plan to resolve those drug therapy problems, and in doing so, establish healthcare goals with the patient. So we look at the clinical goals a patient may have, and then look at their personal goals that they have, and work together with them to really create a care plan to help them with their health, improve their health and well-being. And we also look to prevent any future drug therapy problems. And then finally, we evaluate. We record the actual outcomes of what the patient is doing, where they are at, looking at their progress of their therapeutic goals, and reassess for new problems. And I can't stress how important this is, because follow-up is so necessary within this process. We can't just do a medication consult once on a patient or do a MTM workup once on a patient and really be a part of the therapeutic relationship. We need to follow up to make sure that our drug therapy problem solutions worked and that things are working right and the patient is on track. So it's really building that relationship, and then so importantly, working in collaborations with all of a patient's healthcare team. We have to be an equal team member within that and really make sure that we're communicating with the team members within that so there is a good collaboration working for the patient together. So the foundation of our program, again, is built on that philosophy of process of pharmaceutical care practice, which again really mirrors the PCPCC's comprehensive medication management model. And our responsibilities as a pharmacist are to meet those drug-related needs and commit to meeting those needs. We need to ensure that all of that drug therapy, again, is indicated, effective, safe, and compliant or convenient for the patient. Make sure it's working for them, and work in collaboration with all members of the healthcare team. And I know I may sound like a broken record, but this is so important that we take accountability for the drug-related needs and really work with that team. We as pharmacists can bring that to the table. Our goals of our program are to reduce the overall healthcare costs, to empower patients to take a more active role in their health, and to improve the overall health and wellness of patients. And I am happy to say that we've accomplished all of those goals and continue to accomplish those goals with our MTM program. We have taken care, again, of thousands of patients, and this just shows some data from 1999 to 2011 of what we have done with those drug therapy problems that are resolved. And the thing I really like to point out with this data is drug therapy problems are common, especially in a patient population that has chronic disease and is taking medications, although we've had taken care of many patients with only one medication, and they've had problems with that. But 32% of the patients, or 1 out of every 3 people, have had 5 or more drug therapy problems. So there is definitely a need out there to be filled with medication therapy management. This shows a demonstration of what our drug therapy problems is, and I have seen this repeated throughout the United States. Especially, I've also seen this in Brazil and Spain and other countries that use the comprehensive medication management model. Again, that's important as you look at a patient to make sure that a medication is indicated, that it's effective, then that it's safe and convenient. In my philosophy, I don't really care if a patient is adherent with their medication if it's not indicated for their condition. I actually don't want them taking it then. Or if it's not effective to help them meet their goals, I don't care about adherence until the end. I need to make sure and check off that everything is in order first. So this is what we find when we do that. The 2 most common drug therapy problem categories are needs additional therapy or the dose is too low. And these may flip back and forth between 1 and 2. In this data of our year's experience, they're actually both tied at 27%. But we often find that people need additional drug therapy. Still, medications are one of the most accessible preventative things for chronic disease. And so they need to take therapy, and that the dose is too low. A lot of people have learned to go slow or start low and go slow, and they may not actually have gone back to make sure that the medication started is actually helping to meet the patient's goal. And then our friend compliance does come in at number 3 typically. The other thing I like to point out with this is if we were actually not seeing patients and providing comprehensive medication management, but we were just running claims analysis, which can assist us and may be important in some cases, but we would only hit, we might hit unnecessary drug therapy because of the duplicate therapy, or we may hit some doses too high with that. We're seeing about 13% of the problem then. We're seeing about 13% of the drug therapy problem. We'd be missing a huge piece by not doing individualized comprehensive medication management visits, because you're not going to get to the additional therapy or a dose being too low without being able to fully assess the patient, to be able to have their lab work with them, to be able to assess them physically, to be able to talk to them and understand if they're meeting their goals. So it's so important to see that whole picture and bring that whole person approach into your practice. The other thing I wanted to point out about our Fairview practice is that we do have collaborative practice agreements or authorized protocols that we can use to manage a patient's medication. So we go through a process where we actually get that approved through our Fairview Quality Committee. That is composed of physicians and nurse practitioners, PAs, and we go to there to get all of our protocols approved. It's in place for all of our MTM practitioners are credentialed through our Fairview system as providers, and we can initiate and adjust medications or discontinue medications for around 20 chronic conditions. So a lot of the things, as I kind of talk through here, we're able to make a lot of changes effectively on our own without having to go back to the physician. Now, this is not where we started, and so if you or your organization is not at this place, that's okay. That shouldn't prevent you from providing comprehensive medication management. That's where that relationship gets built. But this is a great way to augment your practice and to grow your practices, to be able to have this in order to make those recommendations act right away. And this is important for us in order to be able to do this. We really need to have access to the lab work and to order labs and to be able to monitor that, because that's just ethically what you need to do. If you're adjusting medications, you need to be able to do all parts of it. And then finally, with the recap of just our Fairview MTM program, getting back to our goals, we really have seen a value on the investment. We've had a reduction in overall healthcare costs, and we have some studies that are available. I believe when this invitation went out, we gave a link to the Fairview Pharmacy Services website, to our MTM website, and there are some studies on there that you can take a look at as well. It shows our 12-to-1 return on investment, looking at a population who had MTM services, and then were compared to a year when they did not have it, and showing that return. We also have increased clinical outcomes, so we're showing the clinical benefit. We had a pilot with our state of Minnesota employees that we worked with who had diabetes, and in the first year, in a 12-month period of time, we actually improved their clinical measures for diabetes, their A1C, their LDL, their blood pressure, smoking status, and if they took an aspirin, from 16% of those patients meeting all those goals to 36.5% of them meeting all goals within that 12-month period of time. So an astounding change when the pharmacist was involved in that care team. We have another study with our asthma patients that were cared for by an MTM pharmacist, where we have something in Minnesota called Minnesota Community Measures. That's an asthma measure. We use the asthma control test. There's also a measurement on the hospitalizations or ED visits that they may have encountered. Do they have an asthma action plan on file? And our state average was 16% of an asthmatic patient having all of those on file in 2011. And our patients with asthma who saw an MTM pharmacist, 59.7% were achieving all of those goals. So dramatic change there in asthma control. And then patient satisfaction. Of course, it's so important to go back to the patient. And 97% of our patients either agreed or strongly agreed that their overall health and well-being had improved because of comprehensive medication management services. So now I'm going to talk to you about where I feel pharmacy's role in the medical home and accountable care organizations needs to be. We know it's important. The statistics are out there. We spend up to $290 billion a year on improper medication use. So we know that the need is there. We know that drug expenditures comprise 15.5% of our healthcare premiums, which is actually the third most costly component in spending outside of hospital care and clinical services. So I don't think that there's a question that pharmaceuticals or pharmacy involvement can affect the cost that our country is incurring in healthcare spend. And really, I think what this comes down to, and I always try to think of the big vision and the big goal of what do we need to accomplish together, and really I see that as the triple aim. It's improving the quality of care, the health outcomes, the clinical measures, the quality measures. It's improving patient experience. And in our case, the colleagues that we work with, the provider experience of what we're doing. And then it's the financial outcomes, which I just alluded to. We know are out there. We know that we can improve the total cost of care. And so looking at that, I think pharmacy completely has a role that we can play in that. The pharmaceutical costs we know are great, and we can impact that and have shown how we can impact that with comprehensive medication management. So our objective here is to develop and implement our capabilities and services to support our goals with that. And again, it's pretty easy to show that we can support the health outcomes. We've shown we can support patient experience, and we've shown that we can support financial outcomes. And our providers as well love working with pharmacists as we're integrated into the team. We actually have studies done too where our providers say that they wouldn't want to work in another system without a pharmacist there once they're used to having a pharmacist incorporated. We can work with our providers to expand their panel size, and this is a growing concern in our country as primary care continues to shrink and our population continues to age. There's going to be need for other people to care for these patients, and I believe that pharmacists providing comprehensive medication management can help fit that need and fill that need. And we know that we can save physician visits. Looking at our data at Fairview in 2011, for every 1.6 MTM visits that occurred, there was one physician visit that was saved. So we know that we can help with that panel size to have our provider partners be able to see more patients and to help fill that gap in primary care. And then we know we also can focus, I think, on our complex and costly patients. That's really where we can make a big impact. That's where our expertise can really be shown and highlighted and needed, is on that population. So we have to pick a population to start with. I believe the complex and costly patients are the ones that we may need to focus on. Teamwork and integration. I've already talked about that a little bit, but it's so critical. Our team-based approach is necessary in order for us to make this work. We have to be a partner with the rest of the care team. And I know that this is possible because we're doing this here. So really between primary care, specialty care, and hospitals, when you think about an accountable care organization specifically, you need to have all of those pieces in place to fully care for a population. And having the relationships between all of those, and it's not even just pharmacy having those relationships. Primary care has to have the relationship with specialty and with hospitals and everywhere around within that, because we really need to understand how we're all managing the patient, how we're all on the same team, and most importantly, how we communicate to make sure that we're reaching the patient's outcomes and goals. So when you look at this, we need to manage and coordinate the risk of patient care. We're going to have that financial risk that's there with the total cost of care, and we need to be able to report out on that. And I think personally that's one of the most challenging pieces right now for a lot of organizations that are making the pathway to a medical home and to the accountable care really gets into the cost and reporting. If you don't have your own health plan or have access to some of that data, that's sort of a whole new world for us. And I know it's a journey that we've taken here at Fairview to really understand our population, to be able to look at it and say which patients are maybe costing the most, which patients don't have the quality that we'd like to see them. And instead of always looking at that on an individual basis, starting to look at that as a population and really be able to take that then and act upon it. So that's a new world for us here. And being able to use EHRs are really, I think, again, a way to augment that. For us here at Fairview, we finally got the same EMR on our hospital side as we do on our primary care side, which is really enhancing the patient care and the patient flow and the transition. So I think that doesn't have to happen, but it definitely helps to augment this journey. And I truly believe that pharmacy is a thread between all these practices. And we're really focusing on the ambulatory side today on comprehensive medication management, but pharmacy is integral on the inpatient side as well within that. So there are many tactics that need to take place on the inpatient side in the pharmacy world as well to be successful as an accountable care organization. Now I'm going to take you down our path, and I've talked about it already a little bit, but our journey at Fairview. This has been so exciting. And really this started about 4 years ago for us when our organization decided we needed to transform how we were going to deliver care. And there's 3 main buckets that we felt that we needed to do that. We needed to change the care, we needed to change our payment models, and we needed to change experience for our patients. Again, getting right to the triple aim. So we underwent something called care model redesign within our primary care sites. We really looked at the bubble of changing care. We worked at how would we do things differently to create a more positive patient experience within that, but also help and impact the quality of care and how providers and the team really felt that they should be caring for the patients. We went from the payment side to our health plan partners and asked them to join us in this journey. So they actually worked with us to help create new payment models in some of the shared savings models and helped sort of fund some of our care model redesign with that. And this is an evolution, as the circle shows, and they're all connected, and it's still a journey for us. I think we're still learning as we go through this how all of these affect each other and what may need to change in order to keep this growing. At the same time as you think of that, we also understood that we needed to look across the whole care continuum. And so if we were going to become an accountable care organization and really be accountable for the health of a population, we needed to look across this. So we needed to look at preventative care needs all the way to the catastrophic, most complex care needs. And we knew that we were focusing right now on people that are sick, that come in our door. We only really think about them or care for them when they hit us in the clinic or in the hospital or in the nursing home, or but we weren't looking always at the preventative. So that was another focus that we had to start to look at and think, how are we going to look at preventative care needs and do that outside of even just a preventative physical every year. So, and I would say for our organization, we're still on that journey. It's a really different way to start to think about it. And I would say that healthcare providers in general are not really, our strength is not to think of the population approach. We're learning, but that's not where we've been taught and grounded. So our focus at Fairview, again, has, I keep reiterating, but it is the focus. It's the patient experience. It's the population management approach, the quality of care, and the total cost of care. And how we were going to look at those is one of the things when we talked to our patients was access was a big deal. For their patient experience, it wasn't just, I mean, they all want good care. Any time someone comes in, they want to have good care provided, but they also want to do it when they can and when it's available to them. So that was a big piece for us, is to think about the access. They also wanted enhanced communication with all members of the care team. When you're a patient, you want to know that everybody's working together. You don't want to think, I'm talking to my pharmacist here who doesn't talk to my physician, who doesn't talk to my physical therapist. You know, they want to know that we're all communicating and that there's one plan of care for them. So again, kind of goes back to the importance that I stated earlier, how when we provide comprehensive medication management, we really need to figure out how we're communicating and incorporating ourselves into that team. And they wanted a clear plan of care. From the population management side, we needed to start to talk about care coordination. And we do have care coordinators within our teams, but I believe we all do a piece of care coordination within, making sure that the patient is being looked at from a holistic approach. If we identify a need when we're doing a medication management visit, we need to help the patient direct to either where they need to go or help them problem solve and have the answers to get them what they need. We needed appropriate care team referrals for us to start to look at our population and say, who should the pharmacist see? Who should the behavioral clinician see? Who should the nurse RN see? And where is that appropriate across our population? So we're reaching out to the patients that may need us most. And then the transitions of care is a big piece. We really needed to start to bridge between our hospitals and our clinics to make sure that we were doing the most that we can for a patient to have a smooth transition. The thing that I love about thinking of things as a population or as a patient is that we often think about them when they hit our doors. But most people, I hope, spend most of their time away from us than they do with us. And so we need to think of that time when they're not with us and what we can do to make sure that they're the most prepared that they can be at home and have the tools that they need with them at home and have the understanding so that they don't get caught up when they're transitioning in to see us or out of our hospitals or our clinics. And then the total cost of care. A big piece of that was looking at readmissions and really ensuring that we have the right person with the right role and the right work. So again, we can effectively apply our team members to the population to get the best results for the patient and the best economical results for the system. So that's kind of our strategy. I like to just talk a little bit about population health, and I'm a very visual person, so this helps me. And again, some of you may be experts in population health, but this is really where I start to think about that. So we had our Fairview population that consists of around, on any given time, about 1 million people that kind of come through our door in a 1 or 2 year period, accessing either our clinics or our hospitals. Then we had our accountable care or population. We have actually many what we called shared savings contracts with our commercial payers, but we also have the big pioneer ACO population that we're caring for. And a rough estimate of that out of the population would be around 18,000, 19,000 patients that fit in that pioneer ACO. And then we looked at kind of the chronic disease. Who would medication management services benefit and out of that population? And a lot of times, again, it's people with chronic disease because they are the ones that are taking medications on a long-term basis. So then we started to think, who is an appropriate medication therapy management patient? And I think this is a question that I get asked all the time. And for those of you looking for the perfect answer, I haven't found one in my 13 years doing that. But this is my best foot forward at what this is, and I'm sure many of you have come up to the same conclusion. It's really, for us, we think of patients that have high risk or have those frequent emergency room visits or hospitalizations. We knew we wanted to focus there because there's high cost, and hopefully we can prevent them from going to the ED or hospital. I don't want to have to go to the hospital, and I don't really like sitting in the emergency room, and I'm betting that most other people don't as well. We also looked at chronic disease and really who's not in goal or in control. I think that that's one of the most impactful ways personally that we have found that we can impact the population. Instead of looking at the number of medications that someone's taking or the number of conditions, which is, can be a logical way to do that if that's all that you have. But if you can look at someone who's not in goal and you know that they're having a problem managing their condition, that's a great area to focus in from a medication management perspective, because medications are also often the tools that help them to get in control. So really help to look at that picture. We found patients who have more than one provider, multiple providers, or use more than one pharmacy often can benefit from this as well, because again, that picture is not clear to everybody likely, and maybe someone's not looking at the whole person there. If they've had a recent change in their health or medication status involving multiple medication changes, that's another trigger that we think is really appropriate. Those persons tend to want to need some help managing their medications. Patients taking high-risk medication classes, insulin, warfarin are two of the big ones that we've seen and that literature has represented as high-risk medication classes. And I wouldn't say that, we bring in every warfarin patient by any means, but if someone's having problems managing their condition or if they're going through a transition and on one of those medications, we know that can often lead them into trouble if they don't have a clear plan. and then a patient referred due to medication questions or concerns. So again, our physician partners. And I will say that in the history of our practice here at Fairview, probably 80%, maybe a little bit less than that, but a really high percentage of the patients that we see come from referrals from the physician. So again, we've built that teamwork, we've built that trust, and that's where we get a lot of our patients from. But in the clinics that we're not, and we haven't been fully integrated into their team, we tend to get less referrals. So it's exciting to start to look at this from a population as well as our physicians referring into us and combining that together, because then we can make sure that we're not missing people just because we're not on location with them. So back to that population approach model, when you looked at the chronic disease population, there was going to be a certain risk within that population. And we also felt that there's people who are going to be low risk and high risk. That's kind of the two buckets that we put them in. And when we looked at the low risk population, we really started to think of patients from the total cost of care standpoint is when can we actually substitute that comprehensive medication management visit instead of just having them see their physician. Because again, here at Fairview, we can manage a lot of the chronic diseases. We can initiate and change the therapy. So when can we be the main driver and not double up with the physician with that? So when can they turn that over to us? And then we also think of how we can reach out to them in different ways. And this may not be pharmacy at all. This might be part of the care team. But when can we get them engaged into group visits or social networking visits, or how can they maybe be helped with a health coach? Doing some things, within the population that don't necessarily require them to come in the door because they are a low-risk patient. And then we looked at high risk, and we looked at that those patients are probably going to need care coordination, and they're probably going to need multiple members of the team. So they might need to have the medication therapy management pharmacist be a part of their team. They might need to have a certified diabetic educator or a clinic RN be a part of their team, and may need other services. These are really the high-risk, probably high-cost patients that are going to need all of us to be a part of that team. And this is kind of a health management model that we're looking at. This is an example of one that could be where you look at that population in between well and very complex, and then you look at kind of the different levels of intervention and team members that may need to be involved. So we have something in our system called care packaging, where we look at the most common chronic diseases and have built standardized guidelines, basically, that are out there, match that with the different diseases. So all of our practitioners within our 44 different primary care sites are following the same evidence-based guidelines and making sure that different things are done. So for example, on a patient who has asthma, making sure that they have an asthma action plan, that they're educated on their inhalers, and the different team members have different roles within that. So a nurse might do education on the inhaler. If a asthma control test is done and the patient is not meeting the goal, if they're less than 20, then that's a referral for our medication therapy management pharmacist. So kind of looking at the level of severity of the patient and where the need is and what team member can best reach and help that need. We do something called C3PO, called the Star Wars lovers out there, which is basically a care conference where the team gets together and they go through patients that maybe they're struggling with or that are not meeting goals and haven't met goals for a while, so they can get the team together and look at those patients to really show the different strengths of the team and say, hey, what do you think? I tried X, Y, and Z. Do you have any suggestions for me? A lot of times the team can come together and help build a care plan for that provider that the provider can go back out and talk to the patient with, or it may end up in a referral to a different care team member to say, hey, I can help you with that, and why don't you send that patient my way, and we'll work together on this. So lots of different places that fall within chronic care, getting to more of that complex chronic care, and then getting the care coordinator and end-of-life resources available as you may need intensified care coordination. We're also going to focus on a new complex care approach where we actually go out to meet the patients where they're at. We're going to have kind of an intensified clinic care model where a team actually goes and we focus on these high-cost populations that may have clinical, social, behavioral barriers that they're facing, and really go out. So they're going to kind of be mobile teams that go out and reach the patients where they're at, so we can help them with their healthcare needs as well. So that's kind of an example of what we're looking at as a system, as a patient-centered medical home and the different levels of services that are available across the continuum of our patient population, and with the accountable care, how we're going to work kind of in that space. And a lot of this focuses right here on primary care and internal medicine, utilizing specialty services as well that's built into those care packages, but a lot of that is focused right out of that medical home basis. So kind of looking at our current and future strategies, chronic disease and wellness is a big one. Our clinic care model, transitions in care, and then the continuum of care services, which I've kind of talked about. So what have we done specifically with medication management in chronic disease and wellness? Well, I've talked about a little bit about kind of this panel of patients. We actually have created a population health tool where we can look at our Fairview population, and we've given criteria for our pharmacists when a patient would be a good candidate for the pharmacist. And I kind of talked about a lot of that criteria sort of comes from who would be a good MTM patient, like I referenced earlier, but actually having the data come in from our EMR and being able to pull that and find which patients are not meeting their goal, or find what patients have multiple ED or hospitalization visits, find what patients maybe have a high risk from a risk scoring tool that we use to really figure out, hey, this person would benefit from having a pharmacist as a part of the team. We're refining our staffing model and delivery to make sure that the MTM services are available when there's need. So again, kind of talked about that. We've had a really close and tight relationships with the clinics that we're in the Fairview system overall, but I still think we can do a lot better with the clinics in the Fairview system that we don't have an MTM pharmacist in, and teach them what patients are appropriate and how we can make sure that we're providing great care for the patients while they're in their medical home. So we've developed some virtual capabilities where we can actually have a computer kiosk set up, and when I say kiosk, it's really just a computer with a webcam on it in a patient exam room, where the patient can be at their clinic and work with the pharmacist at another clinic and see them via the webcam, so the patient can stay in their medical home and be a part of their care team, but still receive the services of a pharmacist when they need it. I've already talked about the collaborative practice agreements, and really being involved in the leadership team for me helps to include and guide the direction of our team and clinic team members. So I guess that's really important too, as a large integrated health system. If I wasn't involved with the leadership and the decision-making abilities, it would probably be less likely that our pharmacists are involved to the extent that they are within the team well. So I think it's strong to and very important to have a good leadership structure, and my bosses and my leaders as well are very well integrated. And so it's really important as pharmacy as a whole to be included, is to have that leadership level there to help guide the direction, but to help make sure that all of us are represented as a part of the care team. Because I think if we're not represented at the leadership level, it's not as strong as a message on the clinic care team that everything is kind of equal within that team as well. And I've already spoken to you a little bit about the care packages, but our pharmacists were involved in most of the care packages. Anything that had to deal with a chronic disease or with medication, a pharmacist was involved as a part of that team to help create and develop those care packages, which was very instrumental as well. We do a lot just as a clinic contribution overall as well, and I talked a little bit about the care conferences. We also have huddles and clinic consults. Many of our pharmacists are also a part of the operations teams within the clinic, so again, that full team integration within is so important, I think, when you're thinking of a a medical home or an accountable care organization, really getting that pharmacy involvement and right in from the ground up within the operational structure. We do a lot of education as well. I think this is where, again, it's to be an important friend, to be an important team member to others. It's what you give and what you get out of a relationship. And so we help them with teaching. We help them with education. We help develop protocols for them for hypertension and lipid management. And again, one of the strengths I think that we as pharmacists can give to the team is make sure that because we're not going to be able to see all patients, as we're seeing the ones that are most appropriate for us, that we're helping those that may see others that don't really need a pharmacist and help them to understand when a pharmacist should get involved and also help them to manage a patient more appropriately when we can't be there as well. And then I talked about the webcam development already as well. In transitions of care, this has been an exciting area to work in as well. And I know I've alluded to it already, but it's really kind of finding those places where the patients get stuck in these transitions. And this has been a really good exercise for us between our inpatient partners and our outpatient teams, and how do we really work together, solely from the pharmacist side and in all areas of the hospital, actually. I mean, not just pharmacy, it's nursing and care coordination. But for today, just thinking about pharmacy, how do we really do that? And what can the inpatient folks do to recognize someone who may benefit from a comprehensive medication management visit on the outpatient side? And how do we make sure that the medication list is reconciled and that the patient understands what they're doing and what patients may need an inpatient consult so they don't get lost through the cracks on the way out? So really looking at that population again and kind of figuring out what resources are needed where and how can we best help our patients during this transition. And then the continuum of care. We have a lot of expanded in the last few years our comprehensive medication management services in specialty areas. So I want to point out here that we still very much take a generalist practice approach, but we have expertise in an area of of those medications. So we have a geriatric pharmacist. We have someone who works in advanced therapies with genetics and lysosomal disorders. We have someone who works with the HIV population, with transplant, chronic kidney disease, oncology. Again, they use that whole patient approach. We don't alter our practice model to only focus on a certain condition. We look at the whole patient and the whole picture, that they have an expertise in a certain condition that helps them to care for that population well. Finally, just want to talk about a few of the Pioneer ACO Quality domains just to kind of get us thinking about how can pharmacy be involved and where can we affect quality. So there's 4 areas. They'll sound familiar from what our strategic goals are at Fairview, but the patient experience, patient safety, preventative health, and the at-risk population. These are some of the example measures. There are 33 quality measures that an ACO will be accountable to report back to CMS on. And so these are some of the ones that I personally picked out that I think pharmacy can have a great impact on. And so there's more than what's just here. But, better care for the individual, that's the patient experience. I mean, providing timely care, communication, health education, shared decision making. I think things are all of those things really fall into our practice model and what we can do to impact a patient. There's the admissions and readmissions, the admissions specific to COPD and CHF. And again, I think in MedRec, I think all of that within our transitions of care work really helps to highlight that and what we can do. Falls risk screening, we know that there's medications that can affect patients with falls. So really helping the team to identify that to improve patients' care with that. Preventative health, a lot of our pharmacies give immunizations now. We can help to identify patients who may need that. Depression screenings, mammography, again, just when you're going in to do that whole person approach to really look, do they have this? Do they know that they should have this, and help be another person on the team to help educate with that. And then there's the clinical measures, blood pressure, the diabetes measures. that I had talked about previously with our MTM practice, that we know that we can impact vascular disease. And then for the first time ever that I have seen in a quality measure, they're actually targeting medication therapy. So there's going to be certain conditions like heart failure where they actually, you have to make sure that the patient's on a beta blocker, or that they're on a therapy to target LDL, or that they're on an ACE or an ARB. So it's really, again, I think a great way where pharmacy can impact making sure that a patient who has that, I mean, we know clinical evidence tells us that that should be, but this is the first time we'll actually be measured to make sure that a patient is on those therapies. So I think we can impact that as well. And then finally, in summary and conclusion, again, I think pharmacists have an important role, both within the medical home and the ACO. I think we need to have a comprehensive, standardized approach when we provide medication therapy management to ensure that our outcomes will be met. We need to provide a consistent practice in order to provide consistent outcomes, and that's going to be needed now more than ever, as everybody needs to know kind of the impact on the team that they're making, and what we can do to help the quality and cost and experience measures. There are many areas that we can impact the health of the population, and there's places that we may need to start in our organizations, but I think that there's many people within the population that MTM can impact. And finally, a little bit of my soapbox, I think as pharmacists, we really need to make sure that we integrate ourselves into the team, and we do that by taking responsibility for our patients' drug-related needs. If you're not willing to take responsibility, it's hard to be an equal team member. As a team, everybody has a role. And so for us to do that, we need to take responsibility, we need to meet a patient's drug-related needs, and most importantly, be held accountable. So with that, I'd like to conclude, and we can open it up for questions.
Well, thank you so much, Amanda, for that phenomenal presentation. I think everybody can take away a lot of the good points that you made here. So if you're, no matter where you are down the path, whether you're involved yourself with a Pioneer ACO, a very complex integrated system that Amanda has part of, or if you're just at the beginnings of trying to figure out how to develop a medical home practice, I think a lot of what Amanda shared will keep many from reinventing the wheel. So again, I wanted to thank everybody for your participation. And thank you, Amanda, for another phenomenal job at sharing with us. I had one question, and then I wanted to turn it over to Ed Webb, who's going to continue with the questions and introduce the new guideline. But I guess one of my questions and comments is, when you are looking at comprehensive medication management in this type of setting, one of the things that we've seen, and you talked about this a little bit, is a reduction in overall healthcare costs. But one thing that I think was a little less clear in your presentation, so therefore I just wanted to either highlight it or let you elucidate it on some, is a lot of those savings are not related to medication cost. A lot of those savings, as we've actually seen across the board with medical home development and ACO developments, are reductions in hospitalizations, reductions in ER visits. You alluded to the fact that as clinical pharmacists are seeing patients in your system, you do reduce sometimes your provider visits, but a lot of times that reduction is not where we typically look, which is in the pharmacy spend. So I just have seen that over and over, and I just thought if you would make a comment about that in terms of overall healthcare costs and sort of how you're measuring that.
Yeah, thank you so much for bringing that up, Terry. So again, if you check out our article on the 12-to-1 return on investment, that's a great example of how you will see that. Most often, because our most common drug therapy problem is needing additional therapy or the dose too low, and less so much with the dose too low, but more the additional therapy, pharmacy costs tend to increase. So we're adding therapies, and therefore in doing so, because medications are a great preventative measure, we're reducing hospitalizations and ED visits. That's the biggest two areas that we have an impact in that. So we tend to have some sort of, and not some sort, but we tend to have an impact on office visits as well, which I shared with you. However, an office visit is nowhere near the expense as a hospitalization is. And so that is impacted as well. But prescription costs do go up, and hospitalizations and ED visits are really what do come down within the whole picture, which can lead to a whole nother conundrum, and where we could have probably a whole nother webinar on where comprehensive medication management services really belong. I believe they really belong in the health benefit side of things, because that's where we have the impact on the cost of care, is within the hospitalization and the ED visits. Right now, in the Medicare world, they live on the pharmacy side of that, and that can sometimes be an issue because we tend to increase the drug costs, and so that can sometimes be controversial with the pharmacy benefit managers, whose job it is to really decrease the drug costs. So there's a little bit of a conflict there. But, I think time will sort that out as more is known and continues to be discovered, and the costs are outlined with medication management services.
Yeah. Well, thank you, Amanda, because I think that's an important point, is that as you go into this and as you set up more comprehensive medication management services, obviously there are some ways that you can reduce the pharmacy spend, especially if you've got ineffective medications or using things that aren't indicated. So there's always some opportunities there, but again, the larger opportunity, and what we see when we do this approach, and as Amanda just shared with you, is usually the drug costs go up. So again, look for those opportunities really to reduce the overall healthcare costs and focus more on getting the patients to clinical goal. And I think that has not been that has not really been the major focus of a lot of MTM programs in the past. And even Part D MTM, as Amanda alluded to, has been one of the criteria has been the drug spend. It has never been focused on high Part A and Part B drug spend. We do have some things around different chronic disease now being focused on, and different medications to treat those chronic diseases. But again, sometimes it's those patients that are the least adherent and are the most confused about their drugs that are having the most problems and aren't adults. So thank you, Amanda. I'm going to turn it over to Ed Webb. Ed is another co-lead with the Medication Management Task Force and has just been so instrumental in bringing about this second edition of the guide. So I'm going to turn it over to him. He's the Associate Executive Director for the American College of Clinical Pharmacy. And Ed is going to take over moderating the last half of this session, getting your questions for Amanda, and then introducing the guide. So thank you, Ed.
Thank you, Terry, and Amanda, thank you so much for your presentation. We do have several questions already submitted, and I'm not sure. What I've tried to do is to categorize them a little bit, and I hope that won't do an injustice to each of the individual questions. But I had one to start out myself, Amanda, and that is, as you describe what's how your focus on population health in particular has evolved and generated. It seems to me, and we're learning this through the work of the PCPCC, not only in medication management practice, but in primary care practice for physicians as well. One of the real challenges in our current system right now is the lack of data within practices, small practices, physician practices, the delinking or the unlinking, lack of linking between members of the care team when they're practicing in silos. Could you speak a little bit more to the importance of how data and availability of data and interconnectivity and interoperability of data among the care team members drives your ability to do some of this work? Because really, the typical physician practice doesn't know, unless they've got a pretty sophisticated EMR, they don't know how many hypertensive patients they have unless they go tabulate it in the charts. Community pharmacies, all kinds of pharmacies have a hard time figuring out those data. So how critical are data to the process of putting this practice in place?
Yeah, I would say that it's very important. And, can you provide care without having that? Of course you can. can you really understand your population without it? I don't think so. So, you know, it's very eye-opening to take a different approach to that, and I think that's why we as clinicians somewhat struggle in that approach, because we've never had access to it. And so, you know, we are fortunate here at Fairview to have built the infrastructure to start to look at our own data. And so we actually, you know, we even don't always have the full picture of what, you know, we would love to have. For example, if someone is using another system within our metro area that is not a Fairview system, I of course don't have the data on that. But I do now have an approach and a way to look if a patient uses one of our hospitals, if they use our primary care clinics. Using the EMR, we can mine out what their most common diagnoses are and what their lab work is and what goals they're meeting. And it helps me to take a look and say, okay, I know within our system we have around 18,000 patients who have diabetes. We have, you know, X number of thousand who have hypertension. And so, you know, that does help you to start to look at the bigger picture and see who's in control and who's not. So I think, you know, really I would see it being difficult to manage, especially an accountable care organization structure, without being able to have the data to understand, you know, where you're at from the clinical picture, from the quality picture, and from the financial picture. And again, here we've been fortunate, and I think, you know, others can do this as well, is to really start to gain some of those partnerships with the payers and really start to see and ask to get some of that data. I know for us, we still don't get it as quickly as we want to, and it may be more aggregated than what we would like, but that helps us to start to see the picture on the cost of care that we're providing in comparison with others in our area as well. But data is so important, I think, if you're going to kind of move to that next level and be able to kind of manage from that population and to really see where the resources need to be and to be able to report out on that. Again, it's not that, you know, from a medical home standpoint, it's not that can't, you know, that can't happen. There's certain criteria that we need to meet as a medical home, and you can have a pharmacist incorporated, and in that way you may want to have certain referral criteria or certain sources that you do on a manual basis. So for example, if someone's not meeting their blood pressure goal and they're on multiple medications already, make that an automatic referral so that, you know, you're not depending on yourself to do that, even though in essence you would be depending on a provider to do that. But when you're looking at the population, we also have to think about the people that don't walk through our door, that maybe just walk through our hospitals or through our EDs, and those are sometimes the most important ones that we want to reach out to, and you don't always know that when you're just looking at your primary care practice. So long drawn-out answer, but really important, I guess, is the key.
Right.
That, you know,
right.
To see that big picture.
Sure. And I think a related question that appears, quite a few related to this question of assuming then that you have access to the data, could you provide a little more information on your process and your kind of your sorting and algorithmic methods for identifying your high-risk patients, the patients that benefit most from a comprehensive approach to medication management? Is that done with particular tools that you can recommend or that you've developed or that are out there in the marketplace where people can begin to look at ways to help sort their population in the ways similar to what you were doing?
Yeah, so we have a little bit of both. We have a product that is made by Optum Symmetry that actually provides a risk score for a patient. There's a prospective risk score. So that's one of the tools that we use that outlines kind of based on the conditions the patient has and how many visits they have, and there's a lot of detail that I don't want to speak wrongly of how they get to that score. That kind of looks from that prospective risk of where a patient may be likely to incur a lot of costs. So that's something that our system has utilized to help us kind of see that picture as well. the population management tool that actually helps us kind of divide the population, I guess might be the best way to say that, to who and what resource or clinician should see a patient is actually a homegrown tool that we've put together. And really just what I did with the help of our IT team is really get a group of clinicians together and sit around this room and say, all right, let's think about our population and where to start and who should see whom. And what I did and what we did in that group is to really take a look at our metrics. So we have certain quality metrics from our payers. We have the quality metrics from the Pioneer ACO. And so that looked like a really good place to start. And took a look at some of those chronic conditions and said, all right, for example, let's take a look at diabetes. Who needs to see a diabetic patient? And then one of the things we were very cognizant of within that is we didn't want 5 different team members reaching out to the same patient. So we kind of created a hierarchy of, if, then, who. So for example, again, with a diabetes patient, we chose to look at it and say, okay, someone who's not meeting multiple goals, so they have to not be meeting 2 or more goals, that's when they should see the pharmacist, because we have the ability in the collaborative agreements to manage multiple areas of the diabetic patient. We can manage their diabetes medications, their cholesterol medications, their blood pressure medications, their smoking medications. So if they're missing lots of things, they go to the pharmacist. If they're just missing their A1C, well, our certified diabetic educators can help manage that. So that's when they get routed to that person. If they're just working on a smoking issue, well, then maybe a health coach can reach in and help. If they also have diabetes but have a lot of behavioral issues or diagnoses of behavioral, then we want to involve our behavioral health clinician in that picture to help the patient through. So it's kind of working with the whole team and taking a look at, maybe a condition and kind of breaking it down and saying if, then, when, and who should be there. So it's kind of the approach that we took with that and kind of walked through the different conditions. So
well, and
that's helpful.
It is, and obviously that makes sense because the pharmacist is not necessarily obviously not the most inexpensive clinician on the healthcare team. So the appropriate deployment of the pharmacist to tackle the things that have high return on investment and yield obviously makes a lot of sense. Somewhat related to that is the issue of use of the pharmacist, and then how you deploy pharmacists. You spoke briefly about specialized focus areas, but several questions on the question list about do all of your pharmacists do this? How do you decide who's an MTM pharmacist and who's not? What does the credentialing mechanism broadly defined look like in your setting? How do you decide who does this work?
Great question. So basically we have an MTM pharmacist team. So it's a job description that lies within our organizational structure. And to be an MTM pharmacist at Fairview, we personally don't require any certain degree. I have people on my team, pharmacists on my team who don't have a PharmD, and I have pharmacists on my team who have their PharmD. That didn't seem as important to us as the willingness to want to take responsibility for a patient's drug-related needs and for the understanding of the pharmaceutical care practice. And so, and just to maybe put a little plug in too, there is a new edition of Pharmaceutical Care Practice, the 3rd edition from Sapoli, Strand, and Morley that really talks about the patient-centered approach. And I say that only because that's sort of our Bible. If sorry, maybe that's too harsh of a comment, but that's what we go by for our pharmaceutical care practice. And so it's really finding someone who has the passion to take care of a patient's related needs, and to do that is more important in our organization. And so it's a job opening that they apply for. They need to have clinical competence to do that. And then we actually run them through a training program. So they need to take care of patients before we let them take care of patients in our system. And so we go through the Peters Institute. There was a pharmaceutical care certificate program where they have to work up 50 patients and understand the practice model. Again, that's the most important part for us, is that we're all practicing on a consistent model and have a consistent practice. So there's nothing, I don't want to say they're not special, because I think our pharmacists are all special, but there's nothing per se, unique about it. It's having them trained and having them understand that they're going to need to take accountability for a patient's drug-related needs. They have to have the clinical background in order to do that. The passion really needs to be there and the understanding of the practice. They do all get credentialed through our health system then as an MTM pharmacist. So it is its own role. It's a unique role. And we have built in Fairview that it really means one thing here. So medication therapy management really means that clinical pharmacist in the ambulatory setting looking at the whole patient approach, and really have educated all of our other team members on what that approach is.
Then somewhat related to that, of course, is the issue of, I'm presuming, I shouldn't presume, these are salaried individuals within your system, I assume. The question always arises, what are the payment methodologies? Do these folks bill either dependently or incident to physician services, or are the value to the program, is that what helps cover the costs of these services, or is it a combination, a hybrid of all of those things? Some forms of payment, some forms of shared savings, some forms of just commitment of the Fairview system to the importance of this activity in their success as an enterprise. How do those payment and cost flows all mix together?
Yeah, so they are salaried, and it's really a combination. From a payment standpoint, we are able to utilize, we don't do any incident to billing. We do utilize the medication therapy management CPT codes, the 99605, 606, and 607. In the state of Minnesota, we have Medicaid as a payer for us, and all of the prepaid medical assistance plans provide coverage for medication therapy management in this comprehensive approach. We also have worked with our commercial payers to be able to get some contracts with them. That's still probably our biggest gap within the payment. We have Part D plans that we provide services for through the Part D benefit, and we've worked a lot directly with employers. So we have a good half dozen or more employers that we work directly with to care for their population. So we have, sometimes we may be a part of a network, such as the University of Minnesota U-Plan has an employer benefit for its employees. We're a part of that network. Or we may own the whole contract for, such as the City of Duluth. We have that contract, and then we deploy pharmacists as a part of our network to care for those patients. So kind of doing it from both angles. So that's some of the payment from a direct payment piece. We also have a number of shared savings contracts with a majority of our commercial payers. And so through that, we provide benefits kind of through an allocation, because we're at risk for the overall, the savings, the total cost of care of that population. And we found when we've deployed a pharmacist into that, again, we show that return on investment. So we don't directly maybe not bill a patient for that, but we're kind of indirectly billing the system for that through those shared savings contracts. We do also provide fee-for-service benefits. So if a patient is not a part of the shared savings or doesn't have the MTM benefit, they can see us and pay an out-of-pocket cost for that as well. So, and then I think throughout time, our system has seen the benefit in this. I mean, when we first started this, no pharmacist could even bill for their services. And so there definitely is a mission, vision, value piece of it as well that helps support us being a part of the shared savings contracts and others because of that, and knowing kind of the value of having a pharmacist as a part of the team.
Thanks. I think that's helpful as well. There are a couple of pretty specific questions. One asking how many patients are in your ACO?
In the total ACO, there's around, I know you're going to record this and try to direct quote me on that, but
well, it's only true for today. That's right.
Yeah, 19,000 is around in the Pioneer ACO. I don't know with all of our shared savings contracts, honestly. It covers a majority of our population. In our active primary care clinics, I want to say we see around 400,000 patients in our primary care walls, and I've been told between 65 to 70% of that population is either in the ACO or in a shared savings contract. So somewhere around that area.
There were a couple of other questions, comments related to the variability in terminology, inconsistency not only in practice but in terminology, and obviously in Minnesota with the approach that the state Medicaid program has taken to pay for this more comprehensive approach. And you've indicated that you use collaborative practice agreements as an important infrastructure piece of that. Several questions and concerns about the inconsistency across states in terms of what a collaborative practice agreement looks like, what it allows the pharmacist to do. Not sure there's an answer to those questions, but just your perspective on how the collaborative practice agreement structure in Minnesota and the state being a significant payer for this have obviously facilitated the development and evolution of your practice.
Yeah, so I think the collaborative practice that's currently kind of in law and where that stands actually was done in 1999, so that came before the state Medicaid program, so that was done beforehand, and I totally understand everybody on the phone kind of raising their hand going, well, we have this and we don't have this, or this is different here. And I've actually done a lot of research on different states to look at their collaborative practice. And I guess my best answer for that is advocate for yourself, get involved, be a part of your organizations that drive that, because I think that's really, it is a state-by-state function based on our legislation within the state. And so, look at some states that you think would want to model that and change that. I know I'm personally a part of a group that's representing a change in our Practice Act in what we're doing, and so we're working on that actively right now, and I've heard other states are doing that as well from the Pharmacy Practice Act, and it takes you to get involved and to be involved in the organizations that are going to help support you in that change. And it takes advocacy, so it definitely takes involving our physician partners and our nursing partners, because they're going to be the ones at the table wondering what we're doing, and so there has to be that collaboration there and involvement early on to help carry that through. So I think around collaborative practice, that's my best advice or answer. And with Medicaid, I think truly one of our strengths there with that was because we were doing that, and Fairview was one of the entities that was doing that and being able to show the benefit of the practice, and that helped to drive along with other practices where the state really said the model needed to be. And again, it was advocacy. It was having the people at the table to say this is the model that needs to be there, and really helping to move that through. And I wasn't a part of that, but I'm really thankful for the people that were, and being able to set that model. Doctors, Sapoli and Strand being there, and Brian Isaacs being there for us to be able to help go and to help have that background there, and that really helped to drive how Medicaid looked at the practice. The results were there; they could see it, and it helped to build that firm foundation of this needed to be a comprehensive model.
Right.
And that really helps set the standard throughout Minnesota then of what the practice is going to be.
Right. I think we have time maybe for one or two more very quick questions. One I can actually answer, amazingly enough. Someone asked that the CPT codes for service delivery be repeated, and those are CPT codes 99605, 99606, and 99607. You obviously have to work with your payers and others to know whether those are recognized and what the valuations of those are. They are time-based codes. You can find out more about them on the eHealth, ePharmacy EHIT Collaborative website that we can get reference to you. We'll make a link to that available in follow-up information on the website. So, but those codes are AMA CPT code approved for time-based codes for pharmacists, direct patient care interventions, direct face-to-face patient encounters, and I'm pleased to learn that Fairview is using those systems. One last question before we just take a few minutes to wrap up and offer a little bit more information about the new resource guide and some other resources that are coming down the pike. Do you have a sense yet, you've been doing this for a while, do you have a sense of what the staffing ratios look like? That is, how many pharmacists per provider team, one pharmacist per how many providers, and or patients? How many patients using a comprehensive approach? How many patients, say, on the tending to the complex side of the patient population? How many patients can a clinical pharmacist see in a day? And then what's the relationship between number of pharmacists and number of physician practices or physician individuals?
That's a million. That's a $1 million question, and I would be lying if I said, yeah, we had that all figured out. And part of that, just to kind of, and not to take this too long, but part of that is because of the breadth of our organization, we sort of, and I don't want to say limited, but to some way limited, our pharmacists to our practice sites. They're there probably 2 or 3 days a week at a clinic site, and more often it's 2. And so if I were to have as many FTEs in the world that I would want and I could open it up, I think that would affect the panel size. And I just want to say that because when I tell you kind of where our panel size is at, that's because there's some limitation there. And so, you know, bear that in mind.
Sure.
But right now, our MTM pharmacists on a good-sized clinic that's well managed and very busy clinic, we can see around 12 patients a day with that, and you know, give or take, but mostly that's going to kind of be our top end of what we would see. And that has to be a combination of new and follow-up in order for us to get there. We couldn't obviously see 12 new patients a day. That would really be more a lot of follow-up than it would be new to the system. Our visits are about an hour for a new patient and about a half an hour for a follow-up patient. So maybe actually it's probably between 8 or 10 a day. It would be more on average. And our pharmacists take care of around 300 to 500 patients per clinic site. Now that doesn't include clinical consults that are done, care conferences that are provided. That is really comprehensive medication management. That's where we're documenting the whole shebang and we're going through everything with the patient and providing that care. So that's kind of where we're at. I think that's going to change, and we're going to learn more about that as we start to, actually roll out the population management approach, where we can see where we are in the clinics that we're not and the patient volume that's there, and really drive the maybe more complex patients into the system, because that's a process that's evolving right now. So I think we'll see, because excuse me, some of the patients that we've seen probably don't have to actually see the pharmacist. They probably could have seen a CDE, and they could have received services where there's many patients that really needed to see the pharmacist and just didn't get properly referred to us. So I think we're going to see some of that change when looking at the population tool just on that ACO population of around 19,000 patients. Around 8,000 of them, according to what we calculated as someone who would benefit from seeing the pharmacist, that number was around 8,000.
So almost half
Yeah,
of that group. Yeah.
That's also a Medicare population who tend to probably have more medications than the typical population. But yeah, so
Sure.
I don't know if that's helpful, but that's kind of where we're at right now.
It is very much. Amanda, I want to thank you very much on behalf of the Patient-Centered Primary Care Collaborative and everyone on the webinar today for a wonderful presentation. Thank you so much for helping lead this important evolution in the practice of pharmacy, and we appreciate your work so much. Just two very brief announcements, folks, to remind you of the PCPCC Summit in Chicago on October 25th. We hope to see a lot of pharmacists and folks interested in comprehensive medication management at that meeting. This presentation and the recording of it and slides will be available on the PCPCC.net website within the next 24 hours, if not 24, certainly by Monday, but probably sometime tomorrow. And the new resource guide, the second printing and revised resource guide, along with the appendix from that new guide as a standalone PDF document, are available under the Medication Management tab of the PCPCC.net website. Those are available for you to look at now. I think you'll find them very consistent with the presentation that you've heard today, and we'll provide you with lots of information and resources to carry forward in your effort to integrate your medication management services within patient-centered medical homes and accountable care organizations. So thanks again to everyone for participating today, and thanks to the staff at PCPCC for their support of the webinar today. Thanks very much.